Hi, everyone, and welcome to today's webinar, Transforming the Non-Acute Supply Chain, How UChicago Medicine Streamline Operations Across All Care Sites. This is Mackenzie Bean, Managing Editor at Becker's Healthcare, and on behalf of Becker's, thank you all so much for joining us today. Before we begin, I'm just going to walk through a few quick housekeeping instructions. We'll begin today's webinar with a presentation, and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into the Q&A box you see on your screen. Today's session is being recorded and will be available after the event. You can use the same link you used to log into today's webinar to access that recording. If at any time you don't see your slides moving or you have trouble with the audio, please try refreshing your browser. You can also submit any technical questions into the Q&A box, as we are also here to help. With that, it is my pleasure to introduce today's speakers. First, we have Gabe Toledo, who is the Ambulatory Supply Chain Operations Manager at UChicago Medicine. He oversees the non-acute strategy and daily operations across the UChicago ambulatory network. Gabe serves as the liaison between the ambulatory clinical staff, supply chain, and other departments within the health system to align on one shared vision. He is a seasoned veteran in the supply chain world with over 20 years experience in ERP systems and lean process improvements, and has played a key role in the success of UChicago Medicine's supply chain department. Also joining us is Rob Martin, Director of Supply Chain and Logistics at UChicago Medicine. In the past 4 years, UChicago's ambulatory footprint has grown exponentially, and Rob has led the efforts to develop a best-in-class supply chain to support that continued growth while driving greater efficiencies. He has also transformed the supply operations at Ingalls Memorial Hospital in Harvey, Illinois, by taking ownership of the replenishment processes for the procedural and OR departments, which had previously been clinically managed. Gabe and Rob, thank you so much for being here today. Really looking forward to this presentation. So with that, I'll turn the floor over to Rob to get things started.
All right, thanks everyone. Hi, this is Rob Martin. We're really excited to be here today and speak with you all about some of the lessons that we've learned over the past few years in the non-acute supply chain world.
Hello everyone, Gabe Toledo here, and excited to be here and share our supply chain non-acute experience.
All right. Well, a little bit of what we want to cover today. We want to talk through with you all the rapid ambulatory expansion that UChicago Medicine has undergone in the last few years and the challenges that that posed for our health system and specifically for us in supply chain, but also some of the opportunities that it created for us to kind of view how we tailor a supply chain solution for this new environment. Then we're going to talk about how we went about implementing that solution. So how we created a playbook, how we created a scalable solution that we could model and kind of mix and match for the different levels of site size and scope as we continue to grow. And then lastly, we're going to touch on where we are today, how we're sustaining that success, how we're making sure that we are driving that continuous improvement mindset to be best positioned for the future and the continued growth of our network. All right, a little bit about UChicago Medicine to start. So we have 4 inpatient facilities with our premier flagship academic medical center in Hyde Park. And then we also have a smaller community hospital, Ingalls Memorial, in Harvey, Illinois, a little bit further south. And we have 8 ambulatory care facilities, over 30 physician office care network practice locations. And that number continues to grow. That's going to be a major focus of our presentation, is that the ambulatory growth that we've seen over the past few years is not slowing down anytime soon. And we need a solution that can continue to meet that ever-growing need. Right now, we're at over 500,000 outpatient encounters in our ambulatory environment each year. About 5 years ago, the UChicago Medicine leadership team and strategy group came up with their 5-year roadmap for what the strategic priorities for the hospital were going to be looking forward. And ambulatory growth was front and center. It was really a premier kind of pillar of those the goals and the strategy of how the organization saw itself positioning itself moving into the future. They see ambulatory growth and expanding our care network One, as a key driver to the future success of our organization, but two, as a paramount need to provide care and access to high quality care to our patients in their communities where they live. We want to bring the standard of excellence of medicine and care that we believe UChicago provides to as many patients as we possibly can. And that means expanding our scope, expanding our footprint in the surrounding regions and neighborhoods to be able to deliver that access to more patients. And so with that growth, that meant that us as a supply chain team, we were faced with a unique challenge of prior to this focus on ambulatory, the supply chain focus really had always been on our academic medical center in Hyde Park. And we had not really positioned ourselves in a way to be able to meet the needs of an ambulatory network. So that posed an opportunity for us to figure out what does that supply chain look like? How do we structure that to be able to support the university and the hospital's mission of growth and greater access to care? But we didn't create this overnight. We definitely started this many years ago with just a handful of sites that Gabe will kind of walk you through.
Thank you, Rob. So yes, 5 years ago, we started with 3 major locations within our Chicago region, and that quickly escalated 5 years ago to 45 sites now, including joint ventures, more physician clinics. We're looking to continue to expand our ambulatory network to make our world-class specialty care more accessible for our patients in the Northwest Indiana region, as well as building a new ambulatory cancer site in our main campus location in Hyde Park. And I'm excited to bring a couple more medium-sized facilities in summer 2021. So how do all this started? The challenges with our rapid non-acute expansion. So our initial state of clinicians managing the process of supply chain was a struggle, and it wasn't working. We had no process in place for new facility openings. Quickly, we realized, that this was a fast task. We had 15 physician practices locations within a 12-month period, and we were averaging acquisitions 1 to 2 sites every month. We had no central point of contact for facilities to work with. There was no lack of communication on pending sites. Our clinical staff were managing the supplies in their spare time and not leaving time for them to, deal with back orders or troubleshoots their daily supply chain routine. Also, staff was unfamiliar with ordering systems and processes. Different ERP systems in the mix, and our favorite different naming conventions for supply chain item masters brought more challenges to the table. Some of our supply room standards were not maintained properly, so again, it was difficult for sites to manage their own troubleshootings. Looking at back orders, missing shipments. We had no analysis of ordering patterns, and in the event POs were not transmitting, there was no method of them communicating to us and troubleshoot things on their own. Right? From a supply chain perspective, we had no standard supply list on how to approach new builds within our rapid non-acute expansion. We had no playbook. Our formulary was all over the place, and we had no visibility to the day-to-day supply chain operations. Basically, we had no strategy for our ambulatory supply chain environment. We needed to create and promote a consistent supply chain experience across all of the sites, and that enable the clinicians to care for patients, because that is what they do. Supply chain people do supply chain work. That is our mantra, and we want to take that away from them so they can offer our patients the best care out there. We had our work cut out. As these sites were opening up, we needed a comprehensive solution for ambulatory.
So yeah, like Gabe highlighted, we definitely had our work cut out for us. So we kind of put in place a number of different steps and kind of key levers for us to initiate creating a solution for this. So first and foremost, we knew that we needed to appoint a key resource and a leader who would be responsible for driving non-acute supply chain strategy, someone who could take ownership of this and create the strategy and the processes to move us forward. And from there, we created a playbook and a checklist for what it took to stand up new sites and make sure that the activation activities were on time and successful. We worked on developing a supply formulary specific to non-acute, having a subset of our academic medical center offering of supplies that was tailored to an ambulatory environment. We worked hard on establishing supply room standards, having our two-bin Kanban barcode scanning system in place where we could have diligent management of supplies and expiration to make sure that we were monitoring items appropriately. And then last, we worked to get metrics and data and dashboards in place where we could measure our progress and know what good looks like, that we were being successful in this, and that we actually had key metrics and KPIs that would tell us where we needed to improve. So really the first main step in this was appointing a leader to drive supply chain strategy for the non-acute environment. What we found when we initially were standing up some of these sites is that oftentimes the stakeholders and the clinicians at these locations felt like they were on an island a little bit. There was times when they had an issue or problem and they didn't really know who to go to. It was difficult for them being off-site to navigate kind of a complex environment of multiple stakeholders and owners of different categories who all only had their one little key piece of the puzzle that they were responsible for. And there wasn't really anybody to link that all together and drive one cohesive solution. So what we did is we implemented our non-acute supply chain leader, who really served as a funnel, connecting our clinicians and our stakeholders to the rest of the supply chain department, but then also other departments as well. This person kind of became the point person to field those requests and those pain points, take them back internally to work with the appropriate person to drive a solution, and then bring that solution back to the stakeholders. This really freed up a lot of time for our stakeholders to focus themselves on clinical care and patient care, which is their priority, and that's where we want their attention focused. And the other key piece was that having one person driving the strategy allowed for a sense of ownership and a key decision maker where we didn't have to vet things through a number of different departments. We had one person who was able to make decisions and drive strategy and create the processes that were needed in this new environment. And then as our system grew, we grew the team around this. So we are at the point now where we have an operations manager, we have a continuous improvement process transformation specialist who is solely focused on driving new process improvements and looking to how do we optimize our supply chain for this environment. And we've also worked on developing levels of support for each of these sites as needed for more on-site presence. The next thing we did is that we knew we needed a playbook for what it takes to stand up a new site. So we started by interviewing all of our stakeholders and key decision makers in every department across the campus, clinical and non-clinical. So we worked with our providers and our nurses and physicians, but we also talked to IT, marketing, plant, EVS, to get a sense for what were the key activities and drivers that they needed to be completed to ensure the successful launch of a new site, and where were those interdependencies with supply chain. And what we found was that just about every department on campus had some reliance on supply chain for activity in one way or another, whether it was procuring medical supplies or equipment or just contracting with different service providers and vendors. So once we kind of understood what those dependencies were, we really wanted to highlight then what were the pain points, what were the areas that these departments and clinicians struggled when activating a new site or just after new site launch, where things weren't running as smoothly as we needed to be. And then once we had that list of pain points and interdependencies and our full kind of checklist of here is all of the activity that needs to be completed for a successful site launch, we worked backwards from day of activation, looking back behind us to 30 days prior, 60 days prior, 90 days prior to say, when do these activities need to be completed in a timely manner so we can hand them off to the next person in line to ensure that we're keeping a good cadence and we're making sure that we're progressing accordingly. So we would use our new site activation checklist and set up weekly calls with all of these key leaders where we could monitor the progress of these milestones and make sure that we were troubleshooting it in real time to say if anyone was experiencing difficulties or running into roadblocks, how do we remove those ahead of time so that we don't run into these issues coming up onto the event of the new launch. And the really great thing that kind of blossomed from all of the work that we put into developing this playbook was we then became part of the core design team over time. So initial state was that we would be brought in, several months before supply launch and had to kind of tailor our solution to the space that already existed or that had already been designed. But through our work of interviewing and really working with these departments well ahead of time, it became clear that supply chain needed to be at the table well ahead of the site already being built, that we need to be in the room with the architects when those conversations were happening. And that's where we are today. We're now, Gabe and I are in the room with the architects, helping to model out what the space planning needs to look like from a supply chain lens, what the material flow in the building needs to look like, and how we can have those conversations with clinicians to make sure that the site is designed in such a way that it makes sense for everybody. And then once the site launched, we knew we needed processes in place to run it successfully.
Thanks, Rob. So our process development, it was key in our success in ambulatory. So our starting point, we took our Hyde Park main campus supply chain processes as our guide. And then we adapted our standard work for ambulatory environments. But we quickly learned as well that, even though things were working properly for our main campus location, we needed to tailor and tweak the processes so that it can work in our fast ambulatory environment. So we redesigned some of the processes tailored to each facility site needs. We recreated new standard works. We even had standard work to how to open properly a cardboard box. Training checklists were in place, attainment measures were created, and now our process and standard work is visible throughout our supply chain, supply rooms, and all of our ambulatory facilities. So managing the non-acute supply chain standards, addressing standardization challenges, it's still going, but it's feasible, it's doable. We adapted our build-outs and organization structure based on space availability. To Rob's earlier points, now that we are engaged in the preliminary project groups, we are able to identify spacing needs based on each facility. Supply rooms are now built, to the space volume, the procedures, the whatever it might be, what type of different specialties are going to be in these new builds. So it was pretty great and successful to be part of these groups now that we have that visibility and work with different departments, to accommodate the supply chain needs. So now that we have a playbook, standard work, and Kanban infrastructure in place, we needed a labor augmentation to support the sites.
Yeah, exactly. Especially as some of these sites grew, the challenge of ordering, receiving, put away, and the volume of activity that represented for these locations was unsustainable for the admins or the clinicians at those sites to maintain. So we worked to develop a labor solution that we could scale across the network. So the approach that we took was to partner with a third-party provider who had done some supply chain work for us in the past with procurement of some different MRO, and they had experience in healthcare supply chain, but not necessarily in a hospital environment. And we worked to get a few individuals in from that group initially, and we developed this training matrix that you see before you, which was all of the key processes and systems that we identified that someone would need to be an expert in to be successful in operating the UChicago brand supply chain at these locations. And what we did is we identified key activities that signified different levels of understanding of each of these processes or systems. So we had objective criteria for what it meant to be an expert in each of these fields. And then we spent a good amount of time up front training these people to make sure that they were really comfortable in leading and really being the face of supply chain at some of these ambulatory sites. And the great thing about the way we approach this is that because we spent a good deal of time and due diligence up front with putting in the work to train these individuals to a degree that they were really kind of masters of the material, then we had a train-the-trainer type of program in place where any new individual we needed to bring on beyond that point, it was not incumbent on Gabe or myself to have to train that new individual every single time. We had folks who were already fully trained and capable of then training others. So with that, we were able to build a very flexible labor pool that we could deploy as needed. And the way we were able to be so flexible with it is that we contracted with this group on an hourly rate basis. So that allowed us to kind of plug and play where we needed support for each site. So if we needed a couple weeks for a specific project for building out a Kanban room in a new facility, we could just have one resource dedicated to that. We could scale, one resource to cover a region of several smaller sites. Initially, some of our larger ambulatory facilities, we would have one person there 2 or 3 days a week for a few hours just to manage the unboxing and the put away. And then as their volumes picked up, they grew to the point where they needed a full-time dedicated resource. And having that flexibility allowed us to justify and really sell the ROI of having these people on site to support the clinicians without always needing to fully have a full FTE there on presence. So this was a really great program that helped us kind of bring supply chain support wherever it was needed across the network on a very cost-effective basis. The other thing we put a lot of focus on was our non-acute specific formulary. So we started with a non-acute formulary from another health system in the area as a benchmark. And that list had just over 13,000 items on it. And we have gone through a lot of due diligence and an iterative process of collaborating with our physicians to boil that supply list now down to where it stands today at about 1,100 items. And we have that supply list broken out by specialty. So we can say, for a new provider starting in peds or primary care or OBGYN, we have a segment of our list that has worked for other suppliers or for other providers in our network that we can use as a starting point. And this allows us to have really great control and standardization across the network so that we can be diligent about what items we're managing. We don't have to chase 1,000 different back orders or mitigation issues. We have a controlled, standardized list that is cost-effective and controlled, but comprehensive enough to meet the needs of our physicians. This, I think, was really a big turning point for us, where we initially started when these new sites would come online by going to the physicians with a blank piece of paper and saying, tell us what you want. And they would come back with a laundry list of items, half of which may not even be suppliers that we use or items in our item master. And it really took a lot of time and energy up front to vet that list, source those items, and kind of work through everything that was on it. Versus now today, we have a new provider come online in a specific care category, we can go to them and say, here is the list for your specialty that has worked really well for us in our network. Please review this and let us know any edits or suggestions that you have, and we can handle those, one-offs instead of having a brand new list that we're working from every time. And we go through a constant refinement with this process. So we have monthly reviews of what purchases are being made on formulary versus off formulary. At least quarterly, we look at purchase history to see if there are items that are on our formulary that have not been purchased in 6 months or a year that we probably need to remove, or things that we're seeing recurringly purchase off formulary that we need to review and say, is this something that should be considered as a formulary item for us? So this has been a major success story for us that we're really proud of. And so all of this is great for what we've done as far as standing up new sites when we've been able to implement our systems and practices from scratch. But as we continue to grow as a network, that inevitably meant acquisition of existing locations as well. And that really posed a specific new challenge to us of how do we implement what's worked well for us into an environment that already has an existing supply chain.
So with that, implementing our new processes through acquisitions, some of our challenges we quickly identified were change management. A lot of these clinicians, that used to manage their daily supply chain activities, they own that model, and I get it. Things are not going to change overnight. And if you think you're a superhero and you think you're going to manage these changes right away, it's not going to happen. You have to start with small wins. You have to earn their trust. Again, starting with small wins and showing our stakeholders our progress, our changes was huge for us. We quickly learned that each area within our acquisitions, were out for itself, and there were no communication between them. A lot of these facilities were ordering the same products over and over, and in the event of back orders and things of that matter, they were not clearly communicating. So we also transformed their heavy use for couriers from a central warehouse location to be site independent. So now they have more visibility to their daily orders, and we can easily tap into their orders and try to mitigate and help them out with their daily activities. We also initiated weekly calls for sites to have a forum to voice their issues and concerns. Prior to that, there was no forum for them, so basically they had no point of contact to address their daily supply chain issues and dealing with vendors and back orders. So we started this weekly call. It was a 30 to an hour meeting. Now it's pretty rare when it lasts more than 5 minutes, and that just shows the amount of impact we have provided to the stakeholders, earning their trust, and it started small. Now we're at the phase where they're coming to us, asking us, when are you guys going to, take over our area? So that shows a lot of our hard work and dedication, and building that trust with clinicians, that's key as well. These are some of the before and after pictures. This was one of our first acquisition sites at our Tinley Park urgent area. As you can see from the picture on the left, there's just clutter all over the place, no visual of power levels, things kept on cardboard, on the floor, not compliant with our standard worker processes. And the after picture on the right shows, our Kanban process, barcode process. From our initial talks in the beginning, we took that Kanban tube-in RFID technology and adapted it to the offsites. But again, space, it's an issue across the ambulatory sites. So we opted to offer them our barcode scanning, where it's more visual, tube-in Kanban, bins are clear, there's no more clutter or boxes on the floor, so our standard work is visible. So now where the clinicians can quickly go in their get what they need and out the door in a matter of seconds. Next slide. We're also taking on converting empty areas. So the top picture is our Flossmoor former pharmacy storage area. So we took this area and just made it our central storage for the Flossmoor facility. It allows us to provide and ordering and receiving processes. Again, space is an issue, and now we have this space for them to pretty much allocate product in the event there's recalls of things of that matter. We can easily facilitate this process and distribute among our different departments within our Flossmoor facility. We're also looking to reduce space. So the picture on the bottom is a former supply room for one of the urgent aid areas in this facility. After our overhaul and our data analysis, do the whole changes, we determined that a second urgent aid room was not necessary because everything was on the primary room, and on top of that, we have our central storage area that allow us to quickly maneuver and troubleshoot issues, when it comes to any back orders or system issues. Slide. And this one here is from our same-day surgery area. So again, we converted unused space, make it functional, clean supply room for the same-day surgery area. So this particular room houses the anesthesia and recovery room supplies. Previously, they had 2 to 3 recovery rooms that were being used as storage. So now we're giving those recovery rooms back to them so they can, do whatever they might need to do with their daily recovery cases, and then offer them a more visual, anesthesia room for them to provide and, again, go in there and easily pick what they need and out the door right away. So we're pretty proud of that process. And again, we're looking for more projects within our same-day surgery in the upcoming months, and we're actually looking to implement them with our barcode scanning and introduce them to our, third-party logistics inventory system as well. The bottom picture is one of our hallways at our Tinley Park Urgent A. Again, there's no receiving space, so everything gets delivered on the hallway there. So now that we have a person there 5 days a week, we're able to quickly receive product and put away. And now they have the space allow for nurses to manage their daily morning huddles, and also, keep us in compliance with our fire and safety codes. So all of this work is great, but how do we move forward and continuously improve?
Yeah, and that's the really key challenge that we continue to work on today. So one of the big focuses for us over the past year has been getting the right data and metrics in place. When we initially started out, we had multiple ERPs. We had very low or no visibility as to how we were tracking success at these sites. So we would use feedback from our stakeholders as our benchmark for success, which was a great early indicator, but was not specific enough, and it was often just kind of very anecdotal, and didn't really give us a focused direction for where we needed to drive improvement, what the data was showing us. So we spent a lot of time working with our business process and our analytics team to come up with a way to take all of our different ERPs and our item masters and combine them into one shared Tableau database, where then we could fine-tune it and figure out what are the right metrics to track and what does success look like for us. We don't want to track things just for the sake of it. We really want to be looking at metrics that mean these are things that we can take action on, that we can drive success, and they're meaningful to us and to our stakeholders. So what we've done is we have now a weekly dashboard that we review and we drive action on, and we can also tailor site-specific dashboards, so we can have informed conversations with the leadership at each of these locations to say, here's what's working really well, here's where we need your help driving improvement in key specific categories. So some of the ones we have tracked there on the snapshot, we measure unfilled lines on a daily basis, and we work to make sure that we're mitigating those issues. We're looking at supply volumes, both in terms of lines and package count, so that we can see if we start trending up at any of these locations, we know that we need to provide more labor support for those sites if they're starting to get overwhelmed. We look at stockouts, expired product, and we're constantly reviewing these metrics to say, are these still the right ones? Are they still impactful? Is there a different way we need to be thinking about this? The heat map on the bottom there, a little bit of an eye chart, but what that is broken out by site and then by cost center within the site, what is a catalog versus non-catalog order. So we can really drill down to specific subsegments within a site to say, what is it that they're ordering non-catalog that means we haven't done a good enough job of providing them a solution through our standard catalog offerings. And is this a repeated thing that we need to look at contracting a new vendor or providing a new option in this space, or is it just a true one-off? And then oftentimes we can have these conversations with the site leaders who may not even know the activity that's going on in some of these different cost centers, so then they can drive action on their end. So this has really been a big focus for us the past year that's allowed us to shift our thinking and be more forward-looking in terms of how we drive supply chain success in this environment. Another really key indicator for us of success is our adherence to the formulary. So we measure percentage of lines, both from a dollar, or percentage of lines and percentage of dollars going through Value Link versus base through our distributor Cardinal, and then as well as percentage of lines and dollars that are formulary purchases versus non. And as you can see, we are month over month 90% or greater on formulary purchases. And this is something that we're really proud of and work very hard to maintain, because to us that is a great indicator that our formulary that we have, while it is controlled and what we consider a well-tuned list, it's also robust enough that it is overwhelmingly meeting the needs of our clinicians, that they don't feel the need to go outside of the formulary very often. So this is a target for us to continue to keep it above that 90% benchmark, and very often review what are those 10% of items that are falling outside that are non-formulary purchases that may be opportunities for us. So a couple closing thoughts to leave you all with. I think our biggest key to success when we were starting out was start with implementing a lead who is responsible for driving strategy in this area. Even if your health system maybe isn't big enough yet that it makes sense to have one person solely responsible for it, maybe it's one hat out of many they wear, but at least it's one person who is responsible for it and is driving the strategy. What we found is when everyone's only kind of worried about their one piece of the pie, things fall through the cracks, and it's difficult to have that unified mindset in that direction. So that was a big key for us early on. Really spend time up front getting the voice of the customer. Go to Gemba, build those relationships with your clinicians, with the administrative staff, with the other departments working at those sites. Understand their pain points and where you can provide value to them. And what we found is that over time, those early adopters and those people that we won over have become our biggest advocates, and they are really great drivers and sellers of our program as we continue to expand it to new areas and come across individuals who maybe express some hesitancy or some suspicions about supply chain. We can point to all the success that we've had in previous locations. Another one is, you don't have to do this overnight. Gabe and I certainly didn't develop any of this from scratch. We started with what we knew. We started with the processes that were working well for us at Hyde Park in our academic medical center, and looked at, through an ambulatory lens, what can we take about these processes to tweak them and tailor it specific to an ambulatory environment. Just start with those small wins. Where can you help them figure out a sub for a back order or expedite a product or just provide them with a contact of someone who can help them. And over time, those small wins add up and they really lead to gaining that kind of trust and that organizational cachet to then sell bigger initiatives and bigger programs to really drive supply chain in this environment to provide value. I mean, that's really the ultimate goal of this, is to be cost effective, to be strategic in how we manage supply chain in this environment, to ultimately free up our clinicians to focus themselves on patient care. And lastly, have a continuous improvement mindset. We really make sure not to kind of stand back and pat ourselves on the back for a job well done. We're always looking at where is it that things aren't working, where can we be better, how do we continue to review our processes with a critical eye to say, what can we do to continue to drive value. Healthcare and supply chain are an ever-changing landscape, and they're a very dynamic environment that if we're not constantly adapting to keep up with that, we're going to fall behind. And we want to make sure that we're positioning ourselves to be at the forefront. So with that, we'll close. Just want to say thank you all so much for taking the time to listen to us. We were really excited to share this with you and happy to answer any questions that you guys may have.
Wonderful. Well, Gabe and Rob, thank you so much. This has been such an insightful presentation. It's been great to see, more about the supply chain journey at UChicago Medicine. So thank you for sharing all that. We'll now begin today's question and answer session. For our audience members, you can submit any questions for Gabe and Rob by typing them into the Q&A chat box you see on your webinar console, and we'll try to get through as many questions as we have time for. We've already had a few great questions roll in. The first is from an audience member who is asking, how do you manage contracts with individual clinics? And the example they share is that Amgen offered a price for nephrology clinics, and as a centralized model, we had to register that clinic with Amgen to access the better price.
Yeah, it's definitely a challenge. There's no, I think, kind of silver bullet there. Our approach is that from a contracting and pricing standpoint, we push all of our suppliers to be uniform across the board, that we view our entire network as one UChicago entity, and we don't accept kind of picking and choosing where they're going to apply different levels of pricing. It all goes through our sourcing team, and it is vetted to make sure that we are upholding kind of one consistent standard across the network. As far as the kind of setting up new clinic activity, that's really been a pain point for us that we've been seeing as we brought on new sites that I know Gabe spends a lot of time working with, is the different credit applications that need to be filled out. We need different licenses, like pharmaceutical licenses or physician licenses for bringing on new sites. That we ran into those pain points early, and the lesson learned that we've had from that is now that's part of our new site activation checklist, is obtaining all of that documentation well in advance of activating a new facility, so that we are making sure we don't run into those road bumps down the road. And it's something that we now have kind of a database of all of those documents that we can pull when needed, and they're readily available for us to be able to provide to those suppliers, so we don't have to dig around and hunt for them each time.
Fantastic. Thanks for elaborating on that, Rob. Appreciate it. The next question is, who does your distribution and how do you work with them on formulary?
Hey, you want to take that one, Gabe?
Yeah, so our primary distributor is Cardinal Health, and we have built a great working relationship with our on-site representatives. We meet on a weekly basis and pretty much address, every issue or concern that comes on board from each of the clinics. To earlier slides where we show the dashboard. So that was a huge win for us, because now we have visual to what's what's on formulary, what's not. And to Rob's earlier point, now we have that data to take it back to the clinicians and, and pretty much to do the whole interview process again, like why are we ordering this product, what is the need for, and whatever feedback they provide us, then we take those that information intake and then work with our sourcing team and and try to bring it to our value analysis monthly BAT meetings. So even though they're ordering non-formulary products, we have the capability of looking at everything that gets ordered for each specific site. But yes, we have a strong working relationship with our Cardinal Health distributor team.
Great. Thank you for weighing in there, Gabe. The next question is, what metrics were crucial when revamping your supply chain department?
That's a good one. I think initially for us, unfilled lines and back orders were the number one focus. Our initial approach when we were standing these sites up was just make sure the product is there when they need it at all costs. That was our sole focus, was just always make sure that they have what they need. And then over time, as we started to get better and better at it, then we started saying, okay, what else can we look at? How can we be more forward-looking with our metrics and our approach to this? So that's when we got to the point of having the more refined formulary that we could track on formulary percentage, non-catalog orders. And now we're looking even further ahead that we have what we call a gap report. That's a forward-looking report we receive weekly that identifies any problem items that our distributor is seeing ahead of time that are not necessarily an issue at the moment, but the trends in the market are saying that this could become a problem item in a week or a month or whatever the lead time might be. And that allows us to get ahead of it a lot sooner and make sure that we have subs in place and that we're being proactive about how we're communicating that information to the sites. So I think it starts with just kind of the basics of unfilled lines, back orders, stock on hand, and then as you continue to get more refined, you can start looking at purchase behavior patterns to understand then how you can optimize inventory levels and refresh your rooms to make sure that your on-hand quantity is meeting the needs but also being cost effective.
Absolutely. I think that's super helpful for our audience to know. So thank you for sharing that. We have another audience member who is asking, how do you get independent physician groups to buy into the changes you're implementing?
That's a good question. So from our initial start, we started the interview process earlier in the day. We talk about coming in, doing acquisitions. So it was difficult in the beginning, because we had no visual. But now that we have that playbook in place and the ability to see our data, we come to them now and offer them our standard formulary, our standard across our UCM environment. Yes, you're going to get pushback in the beginning, but again, building that relationship with the clinicians and physicians, from the start, has helped us. Primary example, we just had a clinic a couple of weeks ago that went live, and they were ordering non-standard needles and syringes. So I quickly identify those products and outline it to the clinician, and met with her and pretty much stated her, hey, this is non-formulary for us, and it's gonna be difficult because it's non-standard for us to get this particular vendor. So the clinician took the information, and not even 2 hours later, I received an email from her stating that the physician was happy with the newer product, and that they were willing to change. Also, if you can get samples, that also works. That way, you can give them the visibility to compare apples to apples. So if you have a different brand syringe and then you show them your standards, they'll be able to easily manage and make a fast, quick decision and provide the details.
Wonderful. Thanks for weighing in there, Gabe. The next question is, What technologies do you use to enhance your inventory management processes?
Yeah, that's definitely been something that's grown over time. So we have our primary replenishment technology is a system called Helios that bolts onto our ERP. And that is the system that we use at some of our larger ambulatory sites. But because of the challenge of having multiple ERPs, and we even have some sites that don't have ERP in place, some of the smaller clinics, we've had to get creative with what solution makes the most sense for each facility. So we have some sites that are ordering through the Oracle iProcurement tool. We have some that are ordering through just Cardinal Marketplace. And what we found is that it's not so much the tool that they're using up front. We definitely work to make sure that there's an easy-to-use tool in place. But then once the orders are in, how do we take that data and analyze it on the back end to help them drive solutions? So what we've done is we have worked to figure out how we pull that all together into one consolidated Tableau database. And that's really what informs a lot of our decision making is pulling all of those data into Tableau, creating metrics and dashboards from there that inform how we can drive improvements at specific sites or specific groups throughout the network.
That makes sense. Thank you so much, Rob. Another audience member is asking, can you talk more about how you leverage distribution partners or vendors to really optimize your supply chain?
Yeah, I can take that one. So I think Cardinal has been great for us. They've really, ahead of time or early on, put in place a non-acute specific team that helped us kind of hone in on our strategy in this space. So they dedicated resources and strategic focus to this environment, that they were key drivers for us in the formulary refinement and management, in helping us benchmark that against other health systems, and helping us to run the reporting to continue to kind of hone in on what the list is that made the most sense for us. They help us with some of our room refresh reports. So we look on a critical basis at how often we're ordering certain products, and at least quarterly for our larger facilities, we look to perform refreshes on all of our Kanban supply rooms to optimize the inventory on hand, because especially the larger facilities, the patient volumes are growing so rapidly that we need to continue to stay on top of it. That we're pulling out items that have no usage, upping par levels on items that are moving quickly, so we can continue to kind of stay ahead of the curve of those patient volumes. And Cardinal's a big driver for us in that space. They've also partnered with us from a freight and logistics standpoint. We've worked with them hand in hand to kind of figure out solutions for delivering the product to the locations. So what we found is that the standard FedEx, UPS, parcel delivery doesn't work across the board. A lot of these sites don't have space dedicated to be able to receive those boxes. They don't have anyone on site at the time the delivery comes to be able to manage that. Oftentimes the clinic hours aren't compatible with delivery time. So we worked with Cardinal to develop a flexible solution that we could tailor the needs of the site to have an appropriate delivery model for them. So for some locations, FedEx or UPS parcel may work a couple days a week, but we may put a private courier delivery in place for the heavier order volume days, or have a solution where someone can deliver to a specific room or person within a facility at a dedicated time, that we have set windows where we know a resource will be on site to be able to receive that. So that was something that kind of we worked with Cardinal over time to really fine tune what that matrix looks like.
Absolutely. I appreciate you sharing that example and a little bit more about what that relationship looks like for us. we have another audience member who is asking, what procure-to-pay and inventory system do you use, and is it the same on the acute and ambulatory side?
So currently we use Oracle procurements for our main campus location. At our sister hospital, Ingalls Memorial, there's Lawson. So we try to leverage and incorporate all processes, from our main campus facility. For the inventory replenishment system, we use Helios. So that gives us more Kanban processes, RFID technology for the main hospital, the OR areas, are using, RFID as well. And then for the ambulatory world, we opted out to use the barcode scanning technology for them.
Great. Thank you for touching on that, Gabe. Another audience member is asking, what was your process for ensuring supplies were identified appropriately for charging?
Gabe, you spent a lot of time on this one.
Yeah, so I mean, everything gets on our item master, regardless if it's Lawson or Oracle. So from the initial state, it wasn't a clean process, but we have a strong sourcing team in our supply chain department that targets and manages those contracts with each supplier. We also have our business process teams that does all of our analytics and data loading into the system. So that's crucial as well. And as we get into the ambulatory world, we take those lists, compare them to our standard formulary, and anything that falls out of that scope of work, then, we put it in a separate bucket, and then we have, people that then manage that as well. Rob and I, keep an eye on that. And then with the help with our Cardinal Health team that provides these daily dashboards and, data, we can easily pinpoint and see what's out of scope and address them separately. But we do have a strong supply chain department that focuses on each of those tasks. We try to keep everything in line, but our goal is to have everything under one shared service, and we're happy to say that we're going to be migrating to a shared service ERP system, which is going to make it much easier for us to manage the daily supply chain processes across the board.
That's great to hear. Thanks again, Gabe. Looks like we have time for one more question, which is, what did you do to rationalize the investment of resources and propose an ROI?
Yeah, that was a big one for us. We started small and we grew responsibly. So, I mean, we just started with having one person who, it was just kind of one hat that they wore, focused on ambulatory strategy. And then as the network grew, that became more and more of that person's focus, and then continued just kind of build a team around them as it made sense. The labor strategy that we developed with our third-party provider of having the hourly rate allowed us to be super flexible with how we deployed that. So we could say for a number of different sites, we can split the cost of this resource up amongst all of these different cost centers, so that no one department or location is really bearing the brunt of it. You're only kind of responsible for one small portion, but you're still getting the service you need. And then we would go back and evaluate what we were able to save in terms of inventory on hand reductions, expired product mitigation, a little bit more of a soft cost, but clinician time no longer devoted to supply chain activity that was now freed up for patient care or other responsibilities. And we were able to kind of bundle all that to say, like, there is a significant ROI when we're able to prevent a lot of these costs up front and only have each site responsible for the level of support that they truly need.
Wonderful. Well, Gabe and Rob, I just want to thank you again so much for your time and thoughtful remarks today. And thank you to Cardinal Health for sponsoring today's webinar. To learn more about the content presented today, please check out the resources section on your webinar console and be sure to fill out the post-webinar survey. Thank you all so much for joining us today, and we hope you have a wonderful rest of your day.
Thank you.